The best option in these patients whom you are planning a posterior segment surgery, be it a buckle or a complicated vitrectomy with silicone oil implant, is to do the A-scan biometry before you take up the patient for the posterior segment surgery. And you can archive it in your records and may even give a copy of it to the patient so that if he's going elsewhere for his further surgical procedures, it can be used. If you're not able to do that, then it is best to do the IOL power calculation using the optical biometer. But in certain situations, when you have a very dense cataract, or if you have a thick posterior subcapsular cataract, optical biometry may not be possible in these compromised eyes. And you have to resort to using an ultrasound biometer. So the challenges when using the ultrasound biometer is that there is an erroneously long axial length measurement, especially if the eye has a silicone oil tamponade. And sometimes in eyes with very dense macular edema, especially in patients who undergo phacovitrectomy and need for a macular pathology. In these patients, there is erroneously short axial length measurement if you are using an ultrasound biometer because it measures only up to the internal limiting membrane and not up to the level of the retinal pigment epithelium. So when there is silicone oil in the eye, it slows down the speed of the ultrasound and there is apparent lengthening of the globe and hence you erroneously measure a longer axial length. The speed of the ultrasound in silicone oil depends upon the viscosity of the silicone oil that you have implanted. And you are operating on a patient who has undergone surgery elsewhere. They usually do not specify the centistokes of silicone oil that has been used. But commonly in most of the centers, we use 1,000 centistokes silicone oil. And the ultrasound speed is around 980 meters per second compared to 1,532 meters per second in the normal vitreous. So there is that much slowing of ultrasound speed. Then again, when you're doing the scan, you see that the retinal echoes, which are supposed to be very highly reflective, become shorter echoes. There are poor retinal echoes. And if you're dealing with an eye which has emulsified silicone oil, there is multiple reduplication echoes in the baseline. All this makes correct calculation of the axial length quite difficult. So in this situation, it is necessary to convert the apparent axial length into the true axial length, making adjustments for the ultrasound speed in silicone oil. If you have an ultrasound biometer which is not very advanced and you cannot set the vitreous gate at a particular level, the velocity gate in the vitreous at a particular level, and there is a uniform velocity gate, what axial length you get is much larger than the true axial length. Then in this situation, depending upon the viscosity of the silicone oil that you're implanted in the eye, you can either convert into the true axial length by multiplying it with a conversion factor. For this, we need to know the type of oil that is in the eye. Or you can use this formula and convert it, and then this converted axial length is added on to the anterior chamber depth and the lens thickness to get the true axial length. But if you have an ultrasound biometer in which the velocity gates can be set, you can set the velocity gate to the type of silicone oil that is inside the eye, and you can get the true axial length measurement. Sometimes you have an incomplete silicone oil fill, and there is a retrosilicone space that between the bubble of the silicone oil and the surface of the retina, which is filled with posteriorly circulating aqueous. The space is maximum when the patient lies down in the supine position where we actually do the scan. So in this patient, it would be a good option to have the patient sitting up and do the scan, where this retrosilicone oil aqueous pooling is minimal. If you look at the refractive index of silicone oil, it is closer to that of the refractive index of a lens. And in most of the lenses, the power of the lenses is located on the posterior aspect of the lens. So this adds up to a hyperopic shift in the refraction, especially if you plan the cataract surgery and if you're not going to remove the silicone oil. The patient will have a transient hyperopic shift in the refraction, and it is your duty to counsel the patient. Counsel the patient and tell them that there must be a transient hyperopic shift, which disappears when subsequently you remove the silicone oil. This hyperopic shift is greatest with the biconvex lenses and least with the viscous lenses. But there are some situations when you have a bad retina and you don't plan to remove the silicone oil from the eye. There are some cases in which we have to replace the silicone oil maybe once every 2 to 3 years. In these situations, it is necessary When you plan to maintain the silicone oil tamponade for an extended period of time, it is necessary to use a lens which is about 3 to 8 diopter more than the calculated power. And subsequently, if at any point down the line you remove the silicone oil, you have to explain to the patient that he is going to have a myopic shift in his refraction. So on these two aspects, you have to counsel your patients before you take them out for surgery. You can also use this following formula to find out the amount of additional power that is needed when the patient needs an extended period of silicone oil tamponade. The second situation is we are doing more and more of phaco-vitrectomies, especially for macular pathology, where the vitrectomy procedure per se is much simpler than for a complicated retinal detachment. In this situation, if you are using the ultrasound biometer, there is an earnestly shorter axial length that is measured. And in this situation, the eyes tend to have a myopic shift in refraction. So you use a lens which is about 0.50 diopter more, especially in eyes when you're doing a phaco-vitrectomy. There may be some situations where it's not possible to get the axial length and there is a damaged anterior segment. There's a lot of emulsified silicone oil in the eye. In this situation, you can opt for an intraoperative biometry after the cataract surgery, an intraoperative retinoscopy, and sometimes you use a CT scan to measure the axial length. We look at the formulas that are used to calculate the IOL power in these compromised eyes. All the newer generation formulas exhibit a better prediction accuracy compared to the traditional formulas. And if you're using a traditional formula, the highly myopic eye with an axial length of more than 26 millimeter, the Bangkok adjustment has to be used.